Welcome you today to this very informative webinar. We will have a deep dive into country approaches, lessons learned, challenges implementing community maternal and perinatal death surveillance and response in Uganda and Zambia. We have the pleasure to have first-hand insights from leading health officials in the Ministry of Health of Zambia and Uganda. We will have first a couple of presentations in order to enter into the topic and in this country experiences. So I have really the pleasure to introduce you and to introduce you to Mary Mbuo, which will give the first presentation. But before that, I'll just a quick note. So we will have two presentations, then the panel discussion, and then we will be able to receive questions through a Q&A. So we ask you to please put these questions in the chat as they come. And also, we will have a panel facilitated by a colleague of ours, which will be introduced later on. So let's continue with the first presentation. We have Mary Mbuo, who is a PhD candidate at the London School of Hygiene and Tropical Medicine in the Faculty of Public Health and Policy. Her research focuses on community engagement in maternal and perinatal death surveillance and response in Kenya. And before embarking the PhD, she spent more than 20 years working in international development and humanitarian response in Africa. So we welcome her to her new this presentation today, and thank you so much, Mary.
Thank you very much, Francesca. Good afternoon, good morning, good evening, everybody, and I'm very grateful for this opportunity. I'll be talking about community engagement in MPDSR. We'll start by thinking about who the community is and what community engagement is. And WHO has defined community engagement as a process of interaction that allows the health system and community members to interact together in relationships and think about how to improve well-being. Community engagement involves a series of is a social process, and it involves a series of interactions. And as well as thinking about the capacities of both the health system and the community members to engage. We also need to think about the purpose for which the engagement process is put together. Next, please. So what is community engagement in MPDSR thought to do? In other words, what do we think community engagement can help the MPDSR process do better? And for starters, it can help with improving data collection on where maternal and perinatal deaths have happened, both in communities and within health facilities. We can also use the death review process to improve quality of care. We can use the process of the death review and the response to improve health-seeking behavior among community members. And then we can involve the community to implement recommendations. And we can also work with community members to mobilize resources for accountability for maternal and newborn health. Next, please. So as part of my PhD and with a group with people from the technical working group in WHO, I undertook a realist review to understand how community engagement in MPDSR works or does not work, what are the processes that support it. And through that process, we were able to identify articles right around the MPDSR cycle as shown in that diagram. Next. So to conclude, what we found about community engagement in MPDSR, it requires building and maintaining relationships between the health system and community members throughout the MPDSR cycle. We also learned that when you make deaths visible, either by displaying the data for community members or having discussions with community members, it provides intrinsic motivation for community members to be engaged in preventing deaths. We learned that it's important to build on the existing health system. Training, support, and supervision of community volunteers and informants is important and will go a long way in supporting this work. We need to create enabling environments for engagement so that when community members where community members can advocate for resources. And then we also recognize, through the literature review, we also recognize that blame culture continues to be a critical barrier for engaging community members. Thank you.
Thank you so much, Mary, for your presentation. So now we will have Dr. Ula De Sani is a public health specialist with about 2 decades of experience implementing programs. Dr. Sheun is a member of the Global MPDSR Technical Working Group that is led by WHO and currently works for the as a Global Associate Program Director in maternal and newborn health for the Clinton Health Access Initiative, supporting the global implementation of sexual reproductive maternal and newborn health programs initiatives. Seun has a master's in public health from the London School of Hygiene and Tropical Medicine and a PhD in public health for the University of Nicaragua, and as consultant for several international organizations. So we are really lucky to have you today, Seun, and happy for you to really continue your presentation. Thank you so much.
Thank you, Francesca. Good morning, good afternoon, everyone. My name is Ula De Sani, and I work with CHAI. I'll be presenting on the overview of community surveillance with a focus on the work that CHAI did working with the Ministry of Health in Uganda and Zambia. So just a little bit about CHAI. We work in about 35 countries, and our mission is to save lives and reduce the burden of disease in low and medium income countries around the world. Next slide. So as a background, high quality routine data on maternal and neonatal mortality is critical to shaping effective interventions. But we see that a number of countries lack a system for tracking births and deaths that happen outside of the facilities. And while we see that facility-based reporting are very well established in many countries, there's still a number of deaths that happen outside of the facility that are not captured. And there are various methods and systems to capture these deaths that happen outside, but they're often lifted. One of them is the DHIS, the surveys that happens. And so we believe that every maternal and neonatal death is a societal and personal tragedy, but it's also a travesty if these deaths are not captured or do not feed into a cycle that that ensure that they don't happen again. And so having accurate data on where the deaths happen, how many of them are occurring are really important to ensure that they inform programming and policy. Next slide. And so to address this, the Uganda and Zambia Ministry of Health and CHAI worked together to strengthen systems and was basically focused on recording community-based maternal and neonatal deaths and stillbirths. And this system was part of a broader integrated program that was aimed at reducing maternal and neonatal mortality, and it had a strong focus on community engagement and sustainability. The program really focused on identifying complications early to ensure that to prevent them become life-threatening and ensure that we refer them to the appropriate healthcare level. And so CHAI worked with the Ministry of Health to mobilize existing community-based volunteers to capture deaths that occur at the community level and ensure that they get reported into a facility-based system or other government system. This system was adopted from a similar model that was implemented by CHAI working with the Federal Ministry of Health in Nigeria. And this was just basically reviving community-based health information system where traditional rulers will identify births and deaths that occur at the community level and report them. And so the program in Zambia and Uganda had a twofold objective. One, to reduce maternal and neonatal mortality by tracking and referring high-risk pregnancies, but also capturing births and deaths. Next slide. So there are 4 steps and a number of essential components that really are important to ensure that we have maternal mortality surveillance systems. One of the first steps is really the recording of the death itself. We want to ensure that the deaths are captured in a timely way and in a comprehensive way. And for that to happen, you have to have first a cadre of community workers or other volunteers or workers that are available that reside in the community. And they need to be trained, they need to have the skills, they need to have guidelines and protocols, they need to have the appropriate forms as well. And they also need to be compensated if they're volunteers. The second step is really the reporting and the reviewing of deaths. It's important that when the deaths are captured, we have clear and different levels of supervisory structures to ensure either by the facility or the district level or a higher authority to share that that they can have oversight over those collecting the data, and also ensure that there are protocols for verbal autopsy and ensure that they happen. Also, the third step is ensuring that the tracking death is entered into a database for visibility. The fourth step, focusing on using the deaths to learn and improve programming. It's important that the death is available and that it's accessible and accurate. And the death is available to MPDSR committees that are trained, that have clear protocols to review those community deaths to ensure that they do not occur. Underlining all of this is ensuring that we have strong government and community engagement and ownership, clear responsibilities, and the skills to either collect the data or to review are available across all of the system. And also thinking how to integrate this within the wider health information system. Next slide. So while we had the strategy in Zambia and Uganda was similar, but the approach in each country was actually contextualized to ensure feasibility and sustainability. As you can see from the table, there are differences between what was done in Zambia and Uganda. For example, the individuals that collected the data were different. There were the Safe Motherhood Group Action Group in Zambia. In Uganda, there were the village health teams. And a similar thing as well, those that were responsible for supervision or higher level reporting were also different. The scope of data that was collected was similar, but also different, and also the frequency of data reported. Next slide. One other thing that was similar across two countries was the fact that they chose to use DHIS2 for data visibility for the data that was captured from community level. And this is because DHIS2 is the official database of the system available in these countries. And also people are well-trained and well-versed in the use. And in Zambia and Uganda, the data collected was linked with the MPDSR system. And in Zambia, health facility staff will conduct verbal autopsy, and in Uganda, health assistant will conduct verbal autopsy. And in both countries, they were both sustained beyond the program and have been integrated into government systems to ensure that the project was not just a one-time, but continued to be implemented beyond the life of the program. Next slide. And some of the recommendations we want to give for those that want to establish or strengthen community mortality system is one, that you have to plan for the long term. You need to plan for long-term integration into facility-based reporting. We have a number of programs or projects that staff, they do have a lifespan. And it's important that from day one, that you're working closely with government to ensure that you're thinking about how this will get integrated into the existing system. And the governments are really eager to see community-based data get operationalized, activated into the existing system. Two, it's important that you build on existing systems and structures. Regardless of what the program is, there's always something available, whether there'll be community health volunteers already there collecting or conducting house visits, or whether there's already a system for MPDSR, they might be dormant or might need to be activated, but it's important that we're working closely with government to build on the structures that exist. Next slide. Another recommendation is to really consider the trade-off between aggregate and detailed reporting. While aggregate data might be easier to maintain over time and is in its use, but some countries might require more detailed information and there may be more wealth of information required, but then the forms become more burdensome as well. And it's also important to establish multi-layer supervisory systems with communities collecting data. There are a large number of community volunteers that collect this data. They also require oversight and support. And this oversight and support comes across all of the levels, from healthcare workers to the district level, all the way to provincial or the national level. And it's also important to ensure that the data is accessible and it can be used, whether they be dashboard or scorecards, to ensure data visualization. But also there should be a feedback mechanism to the community, and that builds trust and ensure that they're engaged and part of the process. Next slide. And I'll end by pointing you to a number of documents that we have on our CHI website. One of the documents has details on all of the learnings that I've just summarized in this presentation, and is on the CHI website on the link. It focuses really more on Uganda and Zambia and has a lot more details. Also on the right, we do have program results that have been published by the Zambian program, of which this program was part of. And I'll end by acknowledging all of my colleagues and partners and those in the Ministry of Health that were part of this work. Thank you very much.
Thank you very much, Seun. It was really informative. Really, I think it's so important to stress the importance of community engagement in MPDSR, because it's often seen as a facility-based intervention, which is not. We really enrich the information with the use of the information collected at community level. So thank you so much for giving us insights on the project and on the program, and on this information as well. So now I would like to continue our discussion with the panel discussion. I invite you to please post in the chat any question you might have for Seun or for Mary. And then we will go into the Q&A later on. So a colleague of ours, Olive Kochman, is the lead of Ending on Every Newborn Action Plan and Ending Preventable Maternal Mortality Secretariat at WHO Geneva. So it's a partnership that supports countries to improve health systems and maternal newborn health and decrease mortality and improve survival and health. So Olive has been working as a learning lead, especially for the Quality of Care Secretariat at WHO, and she will facilitate this panel discussion for now. Thank you so much. Over to you, Olive, to introduce our speakers.
Thank you so much, Francesca. We have a fantastic panel here today. I will invite each of our panel members to turn on their camera as I introduce them. From Zambia, we have Dr. Karen Chizuni, who's the Chief Safe Motherhood Officer in the Ministry of Health. And she is joined by Dr. Paul Mbwala, who's Nursing Officer in Kasama District, working on maternal and child health also at the Ministry of Health. Now, Karen is a public health specialist, and she's the Secretary of the National MPDSR Technical Committee and has been coordinating MPDSR processes in Zambia since 2017. And Paul, he is also the coordinator of the MPDSR and Secretary of the Committee for Kasama District. So you're both extremely welcome today. And next, we have joining us from Uganda, Dr. Richard Mugahi, who is the Assistant Commissioner in charge of Reproductive and Infant Health at the Ministry of Health. He's more than 15 years experience, practice at different levels across the health system, and he's spearheading reforms to improve maternal newborn health indicators, and among those, the weekly national MPDSR community of practice in Uganda. And finally, on our panel today, we're delighted to have Dr. Daniel Morokora, and he's the lead technical advisor and lead obstetrician gynecologist with over 20 years experience in the Ugandan health system. He's co-chair of the National MPDSR Technical Working Group and collaborates across multiple teams of government and private institutions and research at the community level. And is currently the reproductive health advisor to the Uganda Reproductive Maternal, Child and Health Improvement Project. So we are really lucky to have this esteemed panel today. And just before we turn to the panel, I want to reflect on why we're here and really the agenda that we have in the session to follow. So we are extremely keen to learn lessons that can be shared on how to advance on community involvement in improving the quality of maternal, newborn, child health, and lessons that have the potential to be adopted or adapted for further contexts. For those countries that have prioritized community engagement and quality of care, they report that it is instrumental to progress, and their reduction of maternal newborn mortality indicators also identify that as those indicators are improving, they have prioritized community engagement. It's the same countries that are prioritizing community engagement that are seeing this reduction. But what we find, though, that progress is nascent. We see, particularly here, more than half countries are involving communities in defining priorities, but it becomes much less, and particularly for community involvement in MPDSR, it's around a third of countries that are actively engaging communities in this process. This data comes from the 2023 Progress Report on Maternal Newborn Health. And this is data that represents 106 countries reported from the Ministry of Health. So we want to underscore that this is extremely important. Across the quality of care network since 2017, community engagement was a key mechanism that countries were asked to identify mechanisms and implement those. However, 2 external evaluations of the quality of care network in 2022 reported that this progress was nascent, that countries were having difficulty in instituting these mechanisms. Therefore, the learning that we can share and we can identify learning, such as from Zambia and Uganda today, and the potential for that learning to be shared across other contexts and countries is invaluable to us. The next slide shows that there is multiple guidance and recommendations from WHO that have been coming out increasingly as we notice that the improvement in advancing community engagement for quality maternal newborn health is lagging. These guidance posit that community engagement is a core system and it's critical as both a means and an end to ensure accountability and to identify gaps, prioritize concerns, monitor performance, and provide solutions. We can identify that community engagement is possible all along the policy implementation and evaluation cycle. And so to that end, we're really delighted to be here today because the learning we can get from implementers amongst this vast guidance that we have, the actual learning on the ground of how to advance is just invaluable to us. So I'd like to turn to our panel now and to Dr. Karen. I would like to pose the first question. Dr. Karen, welcome. Thank you so much for being here with us. Can I pose to you our...
so much, Pokemon.
Thank you, thank you. So would you be able to describe how community involvement in quality maternal newborn health care in Zambia, can you describe activity at the moment, and in particular community involvement in mortality surveillance as part of your MPDSR processes?
Thank you so much. So actually, community MPDSR is one of the interventions that Zambia has used to actually reduce the maternal as well as perinatal mortality. So according to the Zambia Demographic and Health Survey that we did in 2018, 97% of the women had access to antenatal care services, and that service was actually provided by a skilled provider. And 84% of them delivered at a health facility. But we had 15% of women that still delivered at home. And then the maternal mortality ratio had remained high at 252 per 100,000 live births. And the neonatal mortality rate remained at 27 per 1,000 live births. So this was an increase from the 24 that we had in 2013-2014. So preventing avoidable deaths actually require concerted efforts, including stakeholders that are at community level. And when we look at the community MPDSR, it ensures that maternal and perinatal deaths are actually identified, notified, and audited, regardless of the place of death. So we're looking at those that would have died at home, those that died on transit to health facility, including those that died at the facility. So they also need community engagement so that another death could be prevented in the future. So in a death occurs at a facility, or be it at a facility or a community, you find that facility staff, together with community-based volunteers, conduct community verbal talks to actually understand the social, economic, as well as the cultural factors that would have contributed to that death. So a community meeting is then called for to actually discuss as well as agree on actions to prevent future deaths using information that was collected during the verbal talks. So usually this happens between the 7th to 21st day of the mortality. So what we have seen currently from these interactions with the community is that we have seen an increase in the number of community volunteers or community members that are participating in the MPDSR processes. And we have also seen an increase in the commitment that they have to make sure that they reduce the numbers of women as well as newborns and stillbirths in their communities. So I've also seen that we have an increase of men that have become agents of change and support their wives for antenatal care services, including ensuring that their women or spouses deliver at a health facility. Then also have seen that community leaders have mobilized their subjects and ensuring that their subjects are attending antenatal care services, and they are also making sure that when they go into labor, they deliver at a health facility. So some of them have come up with initiatives where they are contributing money as communities to make sure that when a woman goes into labor, they are assisted with transport to ensure that they deliver at a health facility. So some of the chiefdoms have also developed strategic plans, and these strategic plans address the gaps that would have identified during the MPDSR processes that were held at community level. So some of the communities have also come up with bylaws to restrain their subjects from delivering at home by making sure that they put a charge to it. For example, there are those that charge a goat for a woman that would have delivered at home, or the couple is actually expected to go to the palace and do some work for a stipulated period of time. But because of the distances that we have between where the communities are and health facilities for delivery, most of the facilities or communities have seen that it was important that they construct maternity waiting homes in the facility so that women can actually move to these maternity waiting homes and wait for labor to ensure that they deliver in the facility. Because what we have seen is that for the women that we lost as a result of postpartum hemorrhage, majority of them delivered at home, and before they could reach the facility, we lost them. So these maternity waiting homes are actually situated in the facilities, and women are able to sleep there until the labor comes, and then after delivery, that's when they leave these homes. But we have had issues with these maternity waiting homes because some of the women do not want to get to these maternity homes because there's no food that is being provided. And because of the meals that are not available, some of the facilities are not currently being used. So as a country, to address this challenge that surrounds meals at the maternity waiting homes, we are working with other stakeholders to ensure that we include maternity waiting homes on the plans for the health facilities so that they become part of the facility. And as such, we hope that they'll be funded just like other departments within the facility. So this step has already started, and we are at a stage where now we developed a cabinet memo so that the cabinet can actually sit and review our ideas to see whether this is feasible and it could be included as a policy at national level. Then also have the safe motherhood action groups that my colleague highlighted earlier. So these are the link, they are community volunteers, and they are the link between the health facility as well as the community. And these are the people that actually identify maternal as well as perinatal deaths that happen within the communities. But when we look at the numbers of these SMAGs or safe motherhood action groups, the attrition rate is very high. And one of the reasons why the attrition rate is very high is because they have been engaged as volunteers. So we are looking at working with the Presidential Delivery Unity to actually push for incentives for this important community group so that they'll be able to get a stipend on a monthly basis that will be able to sustain them. Because when we look at the work that they do, some of them spent over 12 hours in the facility, and they don't have adequate time to do their own work. So meaning that they need to have support to make sure that they continue working. So basically, those are the initiatives that we have taken as a country to ensure that the community MPDSR processes are actually institutionalized in our communities, and making sure that the social factors that contribute to maternal deaths are actually addressed within the communities and by community members themselves. Thank you so much.
Thank you so very much. This is excellent, Dr. Karen. You really outlined for us how you've built trust with the involvement of more male members and community leaders, and then acted on what the community is putting forward, their issues with funding, with food, and with the sustainability of the Safe Motherhood Action groups and how you're supporting that. Thank you so much. This is really good examples for us to share. And I'm going to turn the same question over to Uganda now. I think we understand Dr. Richard Mugahi has been traveling and may not have made it. Dr. Daniel, we're going to turn the question over to you, okay? Could you, describe as well the processes that you've taken forward in Uganda for community involvement in quality maternal newborn child health, and then speak specifically on community involvement in MPDSR systems?
Yeah, thank you very much for that question. And indeed, our situation is quite similar to what has been done in Zambia. I recall that we worked together on Saving Mothers Giving Life project, on which later on the work that Chai did in the country was follow-on. Specifically on community surveillance, we had a structure that was generally lying dormant without being utilized. And then we worked on reactivating the VHTs so that they could be able to report through the health system to the health center 3, where we have the health information the health assistants. And then this data was worked on and synthesized so that it could be used at community level. And then this enabled us to start to have dialogue meetings and also a community engagement meetings through the standard structures. And so through this, we're able to provide feedback on the common causes of death, the factors that are underlying that are within either the family, the client, or within the community. And then we started to have communities trying to respond in terms of organizing themselves to see that they have some other referrals. So basically, this is how we have approached this. We've continued to follow this up in the current weekly meetings whenever a death has occurred, and especially that one that has occurred in the community. We trigger the system for us, the health facility can receive this information, and then it can be able to be used. So briefly, that is what we do. There are lots of similarities between what we do here and what has been done in the other country. Thank you so much.
Thank you very much, Dr. Dan. That's very informative. So it's a similar process, though you are using community dialogues, which Uganda has initiated, and then the community involvement in the facility committees. Excellent. Thanks so much. We're going to move to the next question and get a little bit more into depth here. This question is for Paul. Paul, you're working at the district level. You're working to institutionalize these processes, and the project that Jion presented earlier, Chai began this project to strengthen community engagement surveillance systems, and that ended in 2022. And we're really keen to know, could you explain to us what has been learned that can be sustained and scaled up at district and potentially into subnational and national health systems? Would you be able to share with us this learning? So over to you, Paul.
All right, thank you so much. Yes, at community level, we had much support up to, I think, the year 2022, as you have mentioned. And much of those were actually designed interventions at community level. And for us to ensure that those programs have been sustained, actually there was a build-up, like we've been built up from the work that the partner started with us. To start with, we had the lead SMARTs from each facility. Among the SMARTs that were trained, we picked one person to be lead SMARTs per facility. And these people were further trained in maternal and newborn health surveillance system. So even at community level, they were able to pick up with those works. And what we came to see after that was we saw a number of maternal deaths actually being reported even before the facility could get wind of it, because they were much so skilled in now identifying and actually pick up the cases at community level, even though the community was maybe 20, 30 kilometers away from the facility, and be able to report it. And we saw that the process of MPDSR could start even at community level. Headmen were involved, the chiefs were involved. Even when we were doing, for instance, verbal autopsy, community verbal autopsies, we were being actually in the company of these SMARTs. I remember some of the reviews we did at the houses of village headmen at community level, and we designed interventions actually that were able to be sustained by the community at community level. So we saw these actually being enshrined in the community systems. And when we visit these communities, our emphasis is that the community itself has strengthened the community systems in order to sustain the works that were started. So for instance, when there is a death, the community itself actually sits even before we do to review what could have been the problem. So if it was delay, for instance, due to lack of food preparation, transport, the community itself has been able to see it because there are subcommittees that have been established at community level. And the indabas that we did last year, mid-year in 2022, actually helped us to build in this momentum. For instance, at one of the indabas in a chiefdom where we had so many deaths, one of the village headmen where we had a death, and we held a review at his place, actually was able to stand and actually testify to this. So we see that they are now much more prepared with food banks, means of transporting the patients to the facility, and also keeping money in events of an emergency. Then at community level, in order to sustain this, we see that the works of the lead SMAGs has been very important to us. So we began to transition by committing resources to the works that is on the ground by the SMAGs. So every quarter we have the SMAG follow-up activities. So at facilities and in the action plans, we've actually budgeted for an activity that goes on every quarter, every 3 months, where we have a meeting and we follow up the works of the lead SMAG so that we ensure that what is being done on the ground from MNHSS, from the committees that we have established as MPDSR subcommittees at community level are actually taking place. So one of the things that we want also to ensure that we strengthen this activity is to strengthen the non-technical MPDSR committees. I'm glad to say, like in the district Kasama, for instance, this morning we're actually planning that meeting. We've continued so that we involve even the civic leaders, the district commissioner, the mayor of our town, so that actually through even other channels, the chiefs, we are able to sustain this with minimal resources at community level. So those are some of the measures that we have taken to ensure that especially the key works that are being done by the SMAGs are sustained to ensure that the mothers don't keep on dying in the community, and to testify that we've seen actually much fruits bearing from that. For instance, Kasama district, which on average was recording in the last 2 years 4 to 7 deaths, this year so far up to the third quarter, we haven't seen any death either in the community or at facility level. So the other thing we are working on is to ensure that the transport system is strengthened. So in order to sustain these, we are actually, as we are visiting these SMAGs every quarter, we strengthen what we are calling community systems, the referral system, the preparing of mothers as they are pregnant in an event of an emergency. How do they get to the facility? So we want the village headmen, the sub-chiefs and the chiefs to own that process so that once they see that it's a burden to them, they begin to carry it on their shoulder, and in that way we'll be able to supervise and the programs will be sustained. So much of the times when we go to them, what we preach to them, what we want them to carry on is sustaining the program as part of the village system, part of the chiefdom system. So that one has helped us, and this year so far we've seen a reduction, especially in Kasama, of the perinatal deaths, the maternal deaths, and few of these problems. We've had actually problems, near misses, but we've seen that the way the community have responded from the SMAGs themselves because of this knowledge of MNHS has been much better than the years before. So this is the picture now at community level and the steps that we've taken to ensure that we sustain this program. I submit. Thank you.
Thank you so much, Paul. You have, in those couple of minutes, exemplified so clearly and articulately what Dr. Karen was sharing, what was planned and what's been implemented, and what you've been able to achieve over the last couple of years. So the seeds were sown with the CHAI project. What you have now is developed this culture of involving the communities. As you said, it's enshrined in community systems. You've managed to be building the capacities of communities so they can engage as well. And how you've managed to take forward this institutionalization with limited funding, but prioritizing this, involving all the stakeholders, as you said, the mayor, the district leaders, and the chiefs. You know, this is fantastic exemplification of how to institutionalize community engagement. So building on the groundwork of the project at Chai. Thank you so much for sharing this. Now I'm going to turn to another question because we've just come off the back of community engagement, which, you know, was difficult to take forward through COVID. So COVID-19 obviously put tremendous pressures on our health systems. You know, on the one hand, it was a period where, you know, we had to minimize human-to-human contact. And then, but on the other, we saw this, you know, huge importance of community engagement. And as we've come out of the pandemic, community engagement has been highlighted strongly in the response to the pandemic and in all activities moving forward. We want to really emphasize that understanding more about how we improve community engagement systems. So now we would like to ask Dan, you know, as you've come through this period of trying to undertake community mortality surveillance during COVID, you know, how did you continue it and what did you learn? Oh, you're on mute, Dan. 1 sec.
Yeah, so indeed the COVID pandemic was a stressful time, but we also learned a lot from that time. First of all, we had a total lockdown in the beginning where no one, including section of health workers, that we are not allowed to move. But eventually this was permitted, and then we started to engage with our community health workers. And of course, at the time, we didn't actually not know. We suspected that a number of women were dying in the community because of lack of access. And indeed, the first response in the COVID pandemic was set up a parallel system that would start tracking all the COVID cases that were happening. And then in the discussions, we started to notice that actually there were a number of women that were also dying. This triggered a process of generating or creating COVID guidelines for pregnant women and those ones who had just delivered. And over time, by the time we got into mid of the pandemic, we started forming these MPDSR committees that eventually became the weekly MPDSR committee on Thursday. The initial response was to have the M-Track reactivated for some of the community reporting. And then eventually, as the COVID funds started to dwindle, then this was now integrated in the normal M-Track reporting. This is how we started to work. And over time, we note that even though we have not managed to have the whole country report community deaths, we learned that this is an under-resourced area that needs to be supported over time so that we have a strong community surveillance system. We have a number of partners, including WHO, that have been putting in resources in various areas to support community surveillance for MPDSR. So right now, what we do is to ensure that whenever a death is reported by the respective place facility that is nearest to this area, and then this one is discussed in either our Monday meeting, and then eventually we have the final summary of the report and the response in the weekly that we have on Thursday. I think in the area of continuing to do this work, we need to look at how we continue to strengthen this reporting. We are happy that within the Constitution, we had the Registration of Persons Act. Now the National Registration Authority is National Identification Registration Authority is working with us in the Ministry of Health through an MOU to continue to strengthen reporting right from the community to the county level. And we hope that these efforts will continue to bear fruit. Thank you.
Thank you. Thank you so much, Dr. Dan. So you've been able to continue it and identify that this is an area to be prioritized as well, based on the value. I'm going to keep moving fast because we want to leave time for questions, and we just have one more question to put back. And we'd like to bring in Dr. Karen, if you could come back for a moment. And we would like just to hear from you, so reflecting on what we've learned and to take forward into, you know, future policy and planning and implementation, you know, over the course of learning from this work and of course other work you have progressing in country and community engagement, what is one recommendation that you would make to other government officials and implementers that are working to establish or strengthen their community involvement in MPDSR?
Thank you so much. So one recommendation I would make is that they need to invest in community MPDSR, because the community, that's where everything happens. So the deaths are in the community, and even the strategies and actions that need to be taken are at community level. So I think they need to establish community structures and make sure that those community structures are given the knowledge and the skill in MPDSR so that they're able to actually manage the mortalities at that level. But I also want to say that, like for Zambia, we have over the years continued to report community deaths, and we are using the same structures. And even during the COVID-19 pandemic, we were able to receive numbers from the community. So meaning that the structures are already established, and once we give the community members information to say they need to do this, they will actually do it at whatever it takes. So they can even call, because they are not allowed to go to the facility. They could actually call us to say, we have a facility, we had a community death, and this is the woman that died, and this is the village where they're coming from, or it's a baby that died, and this baby was coming from this village. And then what we are also doing as a country is to strengthen our community HIMS system. So we piloted community HIMS system in 5 provinces, but now we are in the process of scaling up so that all the 10 provinces are actually able to implement community HIMS. So one of the indicators that we capture in that community HIMS is actually maternal and newborn deaths. So that information is actually able to trickle from the community up to the national level. And then we're also looking at how we can make sure that the current system that we're using, the surveillance system for MPDSR, be able to sit on the DHIS. So what we are doing now, we are working with the Zambia National Public Health Institute to make sure that we come up with the systems that will be able to make sure that the data that is coming from the community regarding maternal deaths is also able to be viewed in our DHIS. Thank you.
Excellent. That's fantastic. Karen, that's very succinct. You know, firstly, you have to value community engagement and invest in it, establish structures or use existing structures. And this whole piece on monitoring and evaluation, making sure you have the data at facility level and aggregating it up to national level. Thank you very, very much. Dr. Dan, can I pose the same question from learning in Uganda? You know, what's that one recommendation? If you could share, is there something different than what Karen has said, or do you feel that you know, you want to underscore something Dr. Karen has said? Over to you. You're on mute once.
Yes, so these countries tend to have lots of similarities, but what I'd like to mention is that the Ministry of Health recognizes the importance of the community, and indeed the village health teams a structure in our health sector. And recently we have launched the community health strategy. Currently there's a meeting in Entebbe that is unpacking the interventions within that strategy. We also have piloted the community HMIS, which is the digital tool, in 9 districts, and we are noting that there are lessons from there that can help us in the scale-up of this work. Ministry of Health is working on community health worker so that they can be paid. So there is this tendency that VH community health can be subsidized by volunteers, which I think is not very correct. And the ministry is looking into providing some bit of more investment in that area. So for anyone who would like community health to move forward, we need to invest in it. And it's important that the investment should be structured within a strategy that is owned by government to guide the investment. Thank you very much.
Fantastic, Dan. Thank you so much. So you're underscoring this investing valuing the community engagement at the get-go. You mentioned you have a strategy, and also, you know, this idea that within your strategy, moving forward, you want to make sure that volunteers are subsidized. If we look at the questions that are coming through in the chat box, this question about, you know, do you have a strategy that underscores the activity has come up. There's been a couple of questions on it. So I'd like to just start, Dr. Karen, is there a community engagement strategy in place in Zambia?
Yes, so Zambia has a community health unit that sits under the public health department, and we have a community health strategy that was developed in 2022. It was launched and it was also disseminated. So that structure also provides information regarding the incentivization of these volunteers, and that's how we came up with now looking at the strategies on how best we can incentivize the volunteers. Thank you.
Excellent. And just related to that then, because you mentioned maternity waiting homes, is this included in the strategy? Is there, you know, particular policy plans surrounding maternity waiting homes? Have you accounted for that?
Yes, so there is a strategy. So yeah, what we did was to develop an investment case where we actually even costed those maternity waiting homes. So we have what we are calling the reproductive, maternal, newborn, and child and adolescent healthy investment case. That's where we have even put the cost of making sure that we establish these maternity waiting homes, and also making sure that they are finished. Because sometimes you tend to you can build a structure, but if you don't finish it, women will still not use it. So I've made sure that we have put a cost to make sure that they are finished, they have beds, they have cooking facilities, and also they have a lounge where these women can actually sit and listen to information regarding to maternal as well as newborn healthy. Excellent. And then we also have a roadmap that we have also developed. The roadmap also have strategies on how we are going to make sure that it happens. And recently, we have the Presidential Health Initiative, where we are also working together to make sure that these maternity waiting homes are actually established. So we have already done the data collection, and also we have also collected information regarding where we want to prioritize these maternity waiting homes. So in the next 2 or 3 years, we should be able to see a number of them being established in the facilities. Thank you.
Fantastic. Thank you so much. There's so much learning from Zambia about how you are institutionalizing community engagement. I'm going to turn a question back to Mary from the research that she has taken. It's coming up in the chat box. You know, what can you identify, Mary? What are the enabling environments? What are those facets of an enabling environment that ensures that the communities can be engaged?
Thank you for that. Okay, so I should mention the literature I'm drawing from is we included about 47 articles, 47 studies globally that we've used to summarize the findings that we present. And some of the enabling environments are to start with what you have in terms of building on the existing community structures that are already in place. So for example, if you already have community health volunteers who are engaged in other activities, then incorporating those into your MPDSR surveillance activities would be one way to go. If you don't have, in contexts where you may not have this already in existence, then you need to think about the people who are in direct contact with pregnant women, or who have rights that are associated with pregnancy, childbirth, and possibly death. People like religious leaders, priests, and people who register marriages. Those sorts of community groups are key in identifying where births have happened and where deaths have happened, and then working with those closely can be one of the ways in which you create an enabling environment. Another thing is to recognize community capabilities and assets, the things that community members already have. Community members come with a wealth of knowledge about where pregnant women are, about the social barriers they face that contribute to maternal and neonatal deaths. So being able to recognize that community members have knowledge and then tapping into that knowledge through the MPDSR process can be helpful. We can't overemphasize the need to train and supervise volunteers or informants throughout the MPDSR cycle, so that the volunteers that you use are well trained to fill in the notification forms, to participate during social autopsy, but then they're also motivated, both intrinsically and extrinsically. One of the ways in which you can do it intrinsically, one of the things we have found from the data is that, and making data visible to community members. I think the CHAI work has shown how using dashboards or scorecards and helping community members understand exactly where the deaths are, that can be a motivator for people to be engaged in conversations about how to prevent deaths. In terms of extrinsic motivation, you can think about remuneration, particularly for the volunteers who collect the data, or making their work easier in terms of, for example, giving them mobile phones or smartphones or tablets so that they could use those for reporting. Finally, I think we've talked about managing blame culture, because community members will not health providers will not want to work with community members if there's a risk of them being blamed, but community members can also be faced with social stigma, and they don't want certain deaths. Deaths are around illegal abortions and things like that. So you need to manage blame, not just from the health professional side of things, but also from the side of the health system themselves. And finally, to address the social structural barriers. So for example, things like the maternity waiting homes, the things that are beyond what community members can do, but contribute to maternal deaths. Thinking about the creating an enabling health system, respectful maternity care, so that if you are encouraging women to deliver in health facilities, that there are facilities that can deliver the service and deliver it in a way that is respectful. Thank you.
Thank you, Mary. Thank you so much. You have very succinctly summarized a huge amount of literature and the key findings of the enabling environment. Thank you. That's fantastic. I'm going to have one more question because we are almost at time, but Shion, we'd really like to bring you back into the conversation. You've been working across multiple countries on this work for many, many years. And there's a question that maybe you can answer for us. It's like, in the case where there aren't existing structures at the community level, how can a country start with community involvement in MPDSR systems? Would you be able to answer that question?
Thanks, Olive.
Thank you.
A very interesting question. I think for starters, it's really hard to see that there's really no structure. And I say this because it's not going to be an established new structure. Every community has a system already in place. They'll probably have a chief, the head. They have existing cultures and meetings that they already have. And so what we need to do, as Mary said, is to work with what is already existing. For example, in some countries, the priest will have to report a death, or the chief will have to be notified when someone dies. How can we work within those existing systems and build upon them? And for example, some countries don't necessarily have MPDSR systems at the community level, but there are meetings that happen between the health facility and the communities. There are engagements that are core. There are other healthcare workers that could be addressing other things that community workers, like malaria or immunization, that things that already occur. How can we work within those existing systems? So which is why I think it's really hard not to identify something that's already going on. There's always something that's going on that we can build on. But then some of the documents that we put out actually identifies those critical things and the steps that need to happen. But I think looking at the communities to see what they already have, Mary mentioned something that's really interesting, that they have a wealth already. There's the notion that we assume that communities, when a woman dies, that they just assume that they don't take it seriously. They do meet. They have a culture. They have something that goes on. So how can we work within that culture? They know where the woman lives. They know what led to the death. They oftentimes have a lot of information. And then I'll also say that Ministry of Health should also put the community as a first level of the healthcare. Once that is identified, it ensures that it's in your planning, it's in your budgeting, and it also informs who you meet with, the stakeholders you need to engage when you have certain meetings.
Excellent, Sean. Thank you. That's just such a valuable insight. There's always some structure to build from, yeah. And then there's the role from the Ministry of Health to prioritize this. Thank you so much. We have come to time, unfortunately, because I feel that there's so much more we could discuss. But I'm going to hand back to Francesca.
Thank you so much, Olive, and thank you so much for all our speakers for the very important webinar that we had today with a rich discussion. So stay tuned for the next webinars that we will do, as also there will be also other webinars coming out on the community engagement, because it's really an important part of our MPDSR implementation at country level, building on existing systems. So thank you so much to all of you, and see you soon.